Imagine you're trying to pour a perfect smooth layer of concrete, but you have to do it directly underneath an incredibly sensitive, high-tech security laser grid.
Oh, that sounds like a total nightmare.
Right. I mean, you have to get this foundation perfectly level, but if your tools even brush against those lasers, every single alarm in the building is going to trigger instantly.
Yeah, that's not a job I'd want.
It's a logistical nightmare. But what if the concrete you were pouring contained this, chemical that actively swept ahead of your tools and it temporarily disabled the lasers just milliseconds before you touched them?
That would be incredibly convenient.
Exactly. And that is exactly the kind of microscopic engineering polymer chemists have developed for a really sensitive medical procedure. It's called subcutaneous labial deposition.
Which is what we're getting into today, right?
Yes. Looking at this amazing stack of sources you provided for today's deep dive, we are unpacking this fascinating intersection of aesthetic medicine, polymer chemistry, and neurophysiology.
It's a really diverse stack you sent us, too.
It really is. We've got clinical trial data like the Isolane study, pharmaceutical patents detailing HA lidocaine matrix engineering, these complex rheological comparative studies, and advanced pelvic neurophysiology protocols.
All to answer one really specific question.
Right. Our mission today is to understand exactly how the presence of free lidocaine within intimate hyaluronic acid gels basically fundamentally alters patient comfort. We want to see how it turns what sounds like a potentially excruciating surgical concept into a highly tolerable, 15-minute outpatient visit.
And honestly, the engineering behind this is it's a masterclass in solving a biological problem with material science. I mean, let's back up and look at the context of why this is even done.
Yeah, let's set the stage.
We're looking at a space, the labia majora, that often requires intervention when patients experience severe hypertrophy. So, as women age or go through hormonal shifts like menopause, this tissue loses its extracellular matrix density.
Right, so the structure just sort of breaks down.
Exactly. Collagen production drops, endogenous HA diminishes, and all of this leads to a loss of volume and elasticity, which causes significant physical friction, dryness, and a really negative impact on sexual well-being.
Which is a huge quality of life issue for you or anyone dealing with it.
Absolutely. So the medical solution is straightforward in theory, right? Just replace that lost volume.
Sure, just put the volume back.
But the physical reality of how you do that is where your security laser analogy becomes highly, highly relevant.
Because of the anatomy involved. I mean, reading through the sources, the technique requires the practitioner to access the subcutaneous plane, which is just above the fibrous tunic of the labia majora.
And they aren't using a tiny needle for this.
No, they're using a blunt cannula, typically a 22 to 25 gauge, or sometimes even an 18 gauge, depending on how thick the gel is. And the practitioner has to drive this cannula deep into the tissue using the slow, retrograde, fan-shaped technique.
Which means they push the instrument all the way to the furthest point first.
Right, and then as they slowly withdraw it, they deposit the HA gel in this continuous widening pattern. It's literally laying down a specialized foundation beneath a fragile structure without breaking the mucosal surface.
But the sheer mechanical force of a metal cannula moving back and in that retrograde fanning motion through that specific subcutaneous plane, I mean, that is inherently traumatic to the tissue.
I was going to say, considering what structures live in that plane, moving a cannula around in there sounds incredibly painful.
Oh, it's not just mildly sensitive. The pelvic area is one of the most densely innervated regions in the entire human body. You're dealing with the terminal branches of the pudendal nerves spreading all throughout this tissue.
And digging into those neurophysiology protocols you brought to the table, those nerve branches, they aren't uniform, right? The tissue is packed with different types of sensory fibers.
Right, a whole mix of them.
So you have the fast-conducting myelinated I beta fibers, and they're picking up every tiny millimeter of mechanical friction from that cannula moving around.
Like a high-speed alarm system.
Exactly. And then you also have the slow-conducting unmyelinated C fibers, which are the ones responsible for transmitting that deep, aching, diffuse pain. So ripping a 22-gauge cannula through a web of A beta and C fibers without, profound anesthesia, that's a complete non-starter.
Which is exactly why historical pain management in this region has always fallen so short.
Because topical creams don't cut it.
Not at all. Topical creams have a very limited depth of penetration. I mean, they might blunt the initial needle prick at the mucosal surface, but they do absolutely nothing for the deep subcutaneous plane where that retrograde fanning is actually happening.
And what about nerve blocks? Couldn't they just numb the whole area?
They could try a pudendal block,
Yeah.
but that requires deep blind injections. And those carry their own risks of nerve injury, not to mention adding a significant layer of trauma and anxiety for the patient before the actual procedure even begins.
So if the cannula is the instrument setting off the alarms across all those A beta and C fibers, the filler being deposited behind it needs to be the mechanism shutting them down.
Exactly. The formulation has to do the heavy lifting here.
And this is why modern intimate fillers attempt to solve this by incorporating typically about 0.3% lidocaine hydrochloride by weight directly into the hyaluronic acid matrix.
Yes, and the hyaluronic acid itself is cross-linked with a binding agent called BDDE. That's 1,4,4-butanediol diglycidyl ether.
Okay, wait, let's stop right there and look at the chemistry for a second, because this is where I find a massive contradiction in the premise of these sources.
Oh, what do you mean?
Well, HA is a structural polymer, right? The entire reason we use BDDE is to create these covalent ether bonds between the HA chains. It forms a rigid three-dimensional lattice that resists enzymatic degradation and holds physical volume in the tissue.
Right, it creates the structure.
So if you take a pharmaceutical drug, salt like lidocaine hydrochloride, and you force it into that tightly bound polymer web during the manufacturing process, you are fundamentally altering the chemical environment.
I see where you're going with this.
Right. Introducing a foreign compound into that lattice should logically weaken the BDDE cross-linking. Doesn't that compromise the filler's mechanical integrity or make it degrade way faster in the body? Like, you can't just stuff a disruptive molecule into a load-bearing foundation and expect the concrete to hold up the same way.
Honestly, that structural concern is entirely valid, and it was actually the primary hurdle in the early days of formulating HA with anesthetics.
So how did they fix it?
Well, the rheological comparative studies in your sources dismantle that assumption completely. Rheology measures how materials deform and flow under stress. Specifically, they look at the storage modulus, which is the gel's elastic firmness, often denoted as G prime, and the loss modulus, which is its viscous behavior, denoted as G double prime.
Okay, so testing the physical bounce and flow of the gel.
Exactly. And when material scientists tested these intimate HA gels formulated with 0.3% lidocaine and then compared them to identical HA gels without lidocaine, the rheological curves were superimposable.
Wait, superimposable, meaning the G prime and G double prime didn't shift at all. The structural firmness was identical.
Identical, down to the Pascal. The incorporation of the lidocaine has zero negative impact on the gel's stability, its durability under shear stress, or its degradation profile.
That is wild. How is that even possible if you're adding a drug into the mix?
Because it comes down to spatial architecture, not covalent bonding. The lidocaine molecules, they don't actually interact with the BDDE ether bonds. They aren't breaking or replacing the cross-links. Instead, the lidocaine sits passively within the interstitial spaces, the microscopic gaps of the cross-link matrix.
Oh, I get it. It's essentially occupying the empty rooms in the building without knocking down any of the load-bearing walls.
That's a perfect way to put it. And this holds true even when testing other local anesthetics. The studies looked at mepivacaine incorporated into the same matrices and found the exact same preservation of viscoelastic properties.
That's fascinating.
Furthermore, because the BDDE bonds are unaffected, the gel maintains its exact susceptibility to hyaluronidase.
Oh, the enzyme they use to dissolve filler if something goes wrong.
Right. The exogenous enzyme can still access the HA chains to safely cleave them and dissolve the filler if a clinical complication arises or, if volumetric adjustment is necessary. So the safety profile is completely preserved.
Okay, so we have a structurally sound foundation loaded with lidocaine, but to me, that presents a secondary engineering paradox.
It is?
Well, for the lidocaine to actually induce localized anesthesia, it can't remain trapped inside those interstitial spaces of the cross-linked HA gel forever. It has to exit the matrix and physically bind to the receptors on those pudendal nerve branches we talked about.
Right, it has to physically reach the nerves.
And considering the cannula is moving continuously during that retrograde fanning technique, that release has to happen almost instantaneously. I mean, a slow leak over several hours is useless for procedural pain.
Yeah, that wouldn't help the patient on the table at all.
Right. So how does the lidocaine get out of the gel fast enough to matter?
This is where the pharmaceutical patents in your stack reveal a truly fascinating mechanism. They solve this kinetic challenge through engineering the fluid phase of the gel.
The fluid phase?
Yes. The manufacturers don't simply mix lidocaine into a 100% cross-linked BDDE matrix. They add a highly specific ratio of free HA.
Free HA? You mean uncross-linked hyaluronic acid chains?
Exactly. uncross-linked HA is blended into the final mixture.
But wait, uncross-linked HA is incredibly susceptible to enzymatic breakdown. The body's natural hyaluronidases will metabolize and wash away that free HA almost immediately upon injection.
And that rapid dispersion is the exact mechanism of action they are exploiting.
Oh, really?
Yes, the addition of the free HA dramatically alters the kinetics of the lidocaine delivery. If we look at the drug release models detailed in the patents, the movement of the lidocaine out of the gel follows the Higuchi model.
The Higuchi model.
Right. It's a mathematical equation used to describe the release of a drug from a solid or semi-solid matrix.
Okay, and if I remember correctly from the sources, the Higuchi model is rooted in Fickian diffusion. So we are talking about a basic concentration gradient driving the movement, right?
Precisely.
The lidocaine is at a high concentration inside the HA syringe, and the surrounding labial tissue has a lidocaine concentration of 0. So the laws of thermodynamics dictate that the lidocaine will move to equalize that gradient.
Right. It naturally wants to spread out.
But if it's trapped deep inside a dense BDD thicket, that diffusion is going to be incredibly slow. It's limited by how fast the molecules can navigate around all those cross-linked chains.
Exactly. And that's where the free HA changes everything. It changes the viscosity of the fluid phase surrounding those cross-linked chains.
Yeah.
Because the uncross-linked HA isn't tethered to the 3D lattice, it acts as a highly mobile carrier fluid.
Ah, I see.
So when the gel is deposited, the free HA rapidly disperses outward into the surrounding tissue, and it physically carries the dissolved lidocaine molecules along with it.
Wow. So it acts like a biochemical express lane or like a river running straight through that dense thicket. Instead of the lidocaine having to slowly navigate the maze of the cross-linked polymer, the free HA grabs it and just flushes it out into the surrounding mucosal tissue the second the gel leaves the cannula.
That's exactly it. The kinetics are accelerated exponentially compared to a purely cross-linked formulation. The release plot in the Higuchi model shows the amount of drug released is proportional to the square root of time.
Meaning it's incredibly fast up front.
Yes. With the free HA acting as the carrier, that initial burst release, the steep part of the curve happens in a matter of seconds.
Which brings us back to the neurophysiology, specifically those A beta and C fibers we mentioned, firing off danger signals as the cannula tears through the subcutaneous plane. The free HA river is essentially flooding those nerve endings with lidocaine instantaneously.
Right. And at a molecular level, the lidocaine penetrates the neuronal membrane of those pudendal branches. You see, local anesthetics are lipophilic, so they easily pass through the lipid bilayer of the nerve cell.
They just slide right in.
Yep. And once inside, they bind to the intracellular portion of the voltage-gated sodium channels.
And sodium channels are the engine of nerve transmission. When a nerve detects pain like the mechanical stretch of the tissue from the cannula, the sodium channels snap open.
And the ions rush in.
Right. Positively charged sodium ions rush into the cell, the membrane depolarizes, and an electrical action potential fires all the way up the spinal cord to the brain saying, ouch.
But by physically plugging those voltage-gated sodium channels from the inside, the lidocaine prevents that influx of sodium ions.
So it hits the mute button.
Completely. The nerve membrane remains polarized. No matter how much mechanical disruption the cannula is causing in that subcutaneous plane, the nerve physically cannot generate an action potential. The transmission of both the mechanical A-beta signals and the aching C-fiber signals is completely inhibited.
I mean, the engineering is just brilliant. The retrograde fanning deposits the gel, the free HA instantly flushes the lidocaine out of the BDDE matrix via Fickian diffusion, the lidocaine locks down the intracellular sodium channels, and the pain signal is muted in real time as the cannula moves backward.
That's a perfectly timed sequence.
It is. But, theoretical kinetics and microscopic models only matter if they survive the friction of clinical reality. We have to look at the E-Selene study data from your sources to see how this biochemical express lane actually performs in a live patient undergoing labial deposition.
And thankfully, the E-Selene study provides a really comprehensive look at the clinical protocol and the resulting patient experience. Because in practice, practitioners don't rely on the HA lidocaine gel in total isolation.
They use a layered approach, right?
Yes, a multimodal approach. Procedure typically begins with the application of a topical lidocaine and prilocaine cream to the mucosal surface, and that's left under occlusion for about 30 minutes.
Which addresses the superficial sensory nerves at the mucosal layer, mitigating the sharp stinging pain of the initial puncture. But as we establish, it doesn't reach the subcutaneous plane.
Correct. So Following the topical cream, the practitioner will often administer a very small lidocaine bolus, just a localized injection, strictly at the entry point where the cannula will penetrate the fibrous tunic.
Okay, so securing the entry portal. But once that 22-gauge cannula breaches the portal and advances deep into the labia majora, it has left the numbed territory behind. At that point, the heavy lifting of the pain management is entirely dependent on that kinetic release from the HA gel being deposited.
And the data strongly supports the efficacy of that release mechanism. In the Esalane trial, researchers rigorously tracked procedural pain using standardized visual analog scales.
The 1 to 10 scale.
Exactly. And despite the aggressive nature of retrograde fanning in such a densely innervated region, the recorded pain scores plummeted. Patients reported a mean pain score of merely 1.4 out of 10 during the deposition phase.
Wow. A 1.4 out of 10 for subcutaneous tissue expansion in the pelvic region. That is statistically and clinically phenomenal.
It's almost unbelievable until you understand the chemistry behind it.
Seriously. And for you listening, analyzing this data really bridges the gap between laboratory science and clinical impact. You are seeing how the manipulation of uncross-linked HA and Fickian diffusion literally transforms an intimidating, highly sensitive surgical concept into a 15-minute comfortable lunch break appointment.
It completely changes the patient experience.
It does. The patient experiences minimal distress, the practitioner can work methodically without rushing due to patient discomfort, and the entire procedure is elevated from a traumatic event to a manageable aesthetic treatment.
But the immediate comfort during that 15-minute procedure is only the gateway to the long-term clinical benefits.
Oh, right, because the gel stays there.
Exactly. Once the lidocaine is flushed out of the matrix, achieved its temporary blockade, and is naturally metabolized by the liver over the next few hours, the cross-linked BBDE matrix remains firmly in place. And this is where the inherent properties of hyaluronic acid take over.
Because HA is profoundly hydrophilic.
Yes, its molecular structure attracts and binds massive amounts of water molecules.
So it acts as a biological sponge, essentially drawing interstitial fluid into the labia majora to establish deep, sustained hydration from the inside out, which directly counteracts the menopausal or age-related hypertrophy we discussed at the very beginning of the deep dive.
And these post-procedure outcomes are objectively measured across multiple domains in the literature. From an anatomical perspective, practitioners utilize the Global Aesthetic Improvement Scale, or GAIS, to quantify the restoration of tissue volume and elasticity.
And the scores show real improvement.
They consistently reflect significant architectural improvement. But honestly, the most vital metric in these sources is the impact on the patient's functional quality of life, which is measured by the Female Sexual Function Index.
The FSFI. And that isn't just a basic questionnaire, it's a rigorously validated clinical tool that assesses multiple domains of sexual function.
Right, things like arousal, lubrication, pain, and overall satisfaction.
So what did the data show there?
The data reveals a highly significant statistical improvement in FSFI scores following subcutaneous labial deposition with these specific HA gels. Patients experience a profound reduction in dyspareunia that's pain during intercourse, primarily because the restored volume and hydration create a robust mechanical cushion.
Which prevents the painful friction caused by hypertrophic tissue.
Exactly. And the mucosal dryness is alleviated by the hydrophilic nature of the gel pulling water into the surrounding extracellular matrix. These aesthetic and functional improvements are sustained for anywhere from 6 to 12 months, depending on the individual patient's baseline metabolism and the specific cross-linking density of the gel, before the HA is eventually and safely degraded by endogenous hyaluronidases.
We have covered massive ground today by unpacking this stack. We've taken the clinical necessity of correcting hypertrophy and examined the intense anatomical hurdle of moving a cannula through those pudendal nerve terminal branches.
It's a lot of moving parts.
It really is. And then we challenged the structural integrity of mixing a pharmaceutical salt into a covalent polymer lattice, only to find the rheological data proves the BDDE ether bonds remain completely undisturbed.
Which is still my favorite part of the science.
It's so counterintuitive. And then we tracked the kinetics of the free H-air acting as a rapid carrier fluid, leveraging Fickian diffusion and the Higuchi model to instantly flood the tissue with lidocaine.
Creating that biochemical express lane.
Yes. And finally, we saw how that intracellular blockade of voltage-gated sodium channels translates clinically in the E-Selene study, driving procedural pain down to a 1.4 out of 10 and securing long-term improvements in the FSFI scores. It is just a brilliant synergy of polymer chemistry and neurophysiology.
It really is. The current generation of HA lidocaine matrices represents a massive leap forward in material science. But when we cross-reference the kinetic diffusion models with the advanced pelvic neurophysiology protocols in your stack, a fascinating new frontier emerges.
Oh, you mean the differentiation between the nerve fibers? We touched on this earlier. The densely innervated pelvic floor isn't a monolith.
Right, it's not just one type of nerves.
The tissue is a complex web of different sensory fibers with distinct roles.
Exactly. And the sources outline how unmyelinated C fibers, which, again, transmit that slow, diffuse, aching pain associated with tissue trauma, have a much smaller diameter and a totally different threshold for local anesthetic blockade compared to the larger myelinated A-beta fibers.
And the A-beta fibers are responsible for detecting light touch, vibration, and mechanical pleasure.
Right. But currently, the rapid flush of lidocaine via the free HA river is an indiscriminate blockade. It shuts down the intracellular sodium channels across all fiber types in the immediate vicinity, causing total localized numbness.
So wait, if the Higuchi diffusion model dictates the release rate based on the viscosity of the free HA, could polymer chemists adjust the molecular weight or the concentration of that uncross-linked carrier fluid to deliberately slow the Fickian diffusion just enough to change the clinical effect?
That is the cutting edge of the field right now. Could we engineer the HA anesthetic matrix to release the lidocaine at a precise kinetic rate that selectively reaches the threshold for blocking the small unmyelinated C fibers without achieving a high enough concentration to penetrate the thick myelin sheath of the A-beta fibers?
Oh, wow, a targeted blockade.
Yes.
So the gel would selectively filter out the severe aching pain of the tissue expansion and the cannula trauma while actively preserving the mechanical sensory function of the A-beta fibers.
Exactly. The area wouldn't be totally numb, it would just be insulated from pain.
That is incredible. If researchers can fine-tune the rheology and the kinetics to achieve that selective sensory preservation, intimate HA gels would evolve way beyond simple volume replacement and blunt anesthesia.
They would become highly specialized neuromodulators.
Right. They would interact dynamically with the nervous system, potentially preserving or even temporarily isolating and enhancing functional sensation during the entire healing and integration process. That is an incredible concept to walk away with today.
It's a total paradigm shift.
An engineered matrix that doesn't just silence the entire sensory grid, but selectively reprograms the neurophysiology in real time, allowing the body to register touch while remaining completely oblivious to trauma. Well, thank you for bringing this curated stack to the table for us. For you listening, keep questioning the physics behind everyday medical miracles and never stop looking for the hidden mechanics driving the science forward.